Another day there, smiling brightly. She's smiling slightly right now, which we'll show you in a minute, but we're going to concentrate on the upper left tooth. Give me the next slide. You see it from the front, the right cuspid, next slide, in her mouth. This was 2 years ago. The right cuspid, you can see the angulation. The primary teeth actually were taken out. The left cuspid as well. The two primary teeth will come out, and the next radiograph will show you exactly where she is almost a year and a half later. Those teeth have really moved very, very little, even though space was created in the arch. They're not moving. The roots are completely formed. Since there's no movement, there's no question this is the orthodontic problem here. I've drawn her anterior segment here, the maxillary left premolar. The cuspid is unerupted. What we're going to do here is we want to dissect the tissue off. The green is the attached gingiva that we'd like to place on the tooth. So this is straight up, so we're going to make some incisions in the alveolar mucosa, as you're seeing here with the red marker. And then we come down, we're going to do a partial thickness dissection to take the keratinized tissue off of the location in the arch that we want the cuspid to come into. So the tissue's got to be the same that's on this tooth as any other tooth, because we're taking it from where the tooth's going to be moved into. So we dissect that in the alveolar mucosa, not going down through the connective tissue, but just very surface area. And we're going to take the blade and dissect under the alveolar mucosa to get the basal portion of the flap for the pedicle graft. That's what I'm doing with this little blade here. We dissect the tissue off, as we see here, and then the graft comes away. We will take a little piece of tissue off, then we're going to raise it up, and then we go down through the mucoperiosteal tissue and take the bone from over the anatomical crown. The black area is the anatomical crown of the cuspid that's been exposed, and then the gingiva must be placed on the enamel. It's placed on the enamel because within 48 hours that tissue attaches with a hemidesmosomal attachment. So then 7 days later, we're going to come back, take the dressing off. We have the arch wires in there, and then we're going to activate the tooth with 30 power thread. And as it comes down, and it would come down very rapidly, the tissue moves with it just like it does here on the paper. And it brings that gingiva right down into the arch, as you see here on the easel. We want the graft has to be wide enough mesiodistally that it covers the line angle of the tooth that we're going after. So we're going to make sure that the graft is wide enough to cover that cuspid tooth. This is the good stuff. That's what you want on the tooth, and you can take it to the nose. It doesn't make any difference. It's just a matter of dissecting it out. So as we said before, we're going to come around and we're going to scallop a little bit, you know, so we can put it right on the tooth. We'll come down, that's the tissue. Then if the tooth were over here, our incisions would come this way towards the two incisors, or if it were distal, it would go that way so you could take that graft to the tooth. Then once we've got the incisions made, we're going to go right under here and dissect out the base of this graft. And notice the 15 blade is going under the tissue. We dissect that. We can do that all the way to the vermilion border of the lip. This just is not that high up, so we don't have to do it. But same thing, same procedure. We're going to dissect it out. Once we get the base all dissected, then we'll come back and do our partial thickness, as I said before. We don't want a full thickness because the full thickness it will be very anesthetic and thick. So we're going to do some partial thickness dissection here. This is hard tissue, and we're going to go in and find our unerupted cuspid here on the left that has not been doing anything for a year and a half to 2 years. And if it's under the hard tissue here. There's your tooth. Can you see me? Turn to your right. And this is to really make sure that we get as much of the follicular material off as we can. Notice that I haven't embarrassed the lateral. I leave the tissue going all the way around that lateral incisor. is you cannot leave a void under the graft. If there's a big void under the graft, the follicular material can grow under the graft and displace it off of the enamel. So I'll show you what I'm talking about here in just a minute. The placement of the graft is very, very critical. And I want to go slowly and show you how to do that. This is a follicular tissue here. We're not going to get near that CEJ. We'll stay away from a CEJ. We will take a back action plier and take a little bit of the thin labial tissue off, and you have to use the osseous burr to smooth that tissue down so that the graft will lay closely against the, see, we're in the mid portion of the tooth here, but we can't leave this big void with the follicular area under that graft, but that tissue will displace the graft. So here, we're going to do a little more reshaping of the hard tissue. You never want to leave the bone was thick enough here that it didn't stick to the graft, but if the bone sticks to the flap, if it's real thin, then you have to take that off because it's a sequestrum. Here's the graft laid on there, and I can tell you that it's going to look just like the rest of them because that's what she was born with here. Put this so that the dressing doesn't displace it. We go into the mucoperiosteal tissue here.
What size needle and suture is that?
That's a P250 gut, plain gut suture.
And you're coronal to the CEJ.
Oh, yes.
So that you don't risk exposing any of the root surface.
No, we haven't even approached the CEJ or on. You can't displace the tissue to apical. And he'll hold it right there in the position of put it fast. So it goes over the line angles of the tooth. You can see, we'll rinse it off. And it'll look just like this. It'll never cover up again, obviously, when it's that close. The question was, is it important the way you put the dressing on it? And it is. You'll notice I'm going to put this on and put the pressure towards the palatal and not put any apical pressure on that area. Here again, the dressing, let me just rinse that off so you can see it. And that's packed for 1 week. That's packed for 1 week.